And
Thanks,
yeah,
bud.
welcome, Jason.
Good
Are
seeing
you
you.
ready to
Kane.
do
Good
this
seeing you
thing?
again.
So I know, I know that a lot of folks tuning in are potentially at the edge of their accreditation window. So that anxiety that Brett mentioned in the intro is a real life anxiety. This is not hypothetical anxiety for some folks. Like they may
Hmm.
have just registered for this event to hear from you, Jason. So no pressure, but
All
everyone's
right.
gonna lay on you. Yeah. Um, but to that point, and this is specifically for everyone that's tuning in live on this busy Friday afternoon. I know you carved out time to be here with us, and I want to make it worth your time to tune in live. If you have any questions or any comments throughout this entire 1 hour discussion that we're about to have, put them in the Q&A widget on your screen somewhere, and I'm going to try my best to weave in those questions as we go. So don't feel like you got to save it to the very end if there's something that Jason says you want clarity around, especially for those of y'all again that are like staring this accreditation visit in the face and you want to walk in there with confidence. That's my goal for this session. That's what we're going to be pulling out of Jason over the next 60 minutes. So without further ado, we got a little bit of intro here from Brett on who you are, but is there anything else, Jay, that you want to kind of throw out there to give some background or some nuance to who it is that we're
Uh,
talking to today?
sure. I mean, I can tell you that I've been doing sterile processing it was a lean into the HLD world, which is very rare in that instance. Most people are sterile processors or they're HLD reprocessors. So I have both. It's been a very unique perspective. But that being said, I'm just your friend. I've just been doing this for 21 years, and I just want to see people be successful because ultimately, if one SPD is failing, we're all failing.
Right. Yeah, yeah, and everyone's at risk because failure is not, as we know, it's not just about passing the accreditation. Like this means something for patient safety, which we'll get into here um, in a moment. But before we get too deep into the topic at hand, anytime we talk to someone who's got an interesting job title like yours, I always like to ask the question, um, what exactly do you do at this level? Number one, like what's your scope? What's your day to day look like? But number two, um, how did you prepare? How'd you get ready when the time came to put in your application and your resume and be competitive in this? Because I know there's going to be a lot of folks out there that are like, hey, I want to do what Jason does. I love this industry. I want to grow, but I need to know how to get there.
Yeah, yeah. So again, it's years of experience, but it's also not just working within the sterile processing industry. So
Mm-hmm.
I've made a lot of friends in the infection prevention world. I've made a lot of friends in the quality and regulatory world. And so when that occurs, I've gotten involved in the AME standards. You want to be able to branch out and recognize, we'll say the downstream and upstream effects of the SPD world. And if you can actually get in there and have, we'll say, a little bit of knowledge that you're dangerous, that makes it a lot easier to actually branch out and be kind of that system, we'll say, person or that regional role. So my current role, I'm the regional director of operations for sterile processing. I'm over 3 hospitals within Common Spirit. Prior to that, I was the regional director over 3 ASCs and 2 hospitals around just the quality program for high level disinfection and sterilization. So jump back into the operations because I enjoy seeing the aha moments and the light bulb moments from the frontline staff. But I also got to bring on a really, really great team of we'll say, managers and leaders to start building a nice, fantastic program here in the Common Spirit world.
Hmm. Yeah, that piece I think is really helpful to kind of think beyond what you're doing in your own career in your own space, but also like what's going on out there around you to be prepared to equip yourself with that information because that just makes you a better leader. And if you're in that role, obviously it makes your system stronger to your other point. Um, and so, yeah, really helpful feedback. If anyone else has any kind of career related questions on this topic, please throw them in. We'll either answer them later on or We can get a follow-up from Jason later. Okay, topic at hand. We got a lot to cover here.
Yeah.
Accreditation. Let me start here with a softball. Why is this topic such a big deal? Accreditation at the system level for HLD. Why spend an hour talking about it on a Friday afternoon?
Well, honestly, Hank, it's truly the low-hanging fruit within a regulatory visit. Um, it's easy. A lot of these surveyors don't have to be, really experts in our field to literally walk into, a GI space, a clinic, an OR, an SPD, and very, very quickly go, man, that doesn't feel right. And I'm going to go ahead and start digging and start nitpicking and start pulling at the yarn ball until it unravels. A perfect example, we had a local hospital here recently that just went through a state survey, a state complaints, and ended up actually, they weren't even there for SPD, and they spent another 5 days digging into SPD. So they weren't there for SPD. They weren't there for high level disinfection. They were actually there for a patient complaint about something else. And lo and behold, it turned into from a 2-day, maybe a 1.5-day survey to a 7-day survey.
Hmm. And is it low-hanging fruit because it's easier to get into these departments? Is it low-hanging fruit because there's so many things can go wrong? Like how would you kind of categorize that, I guess?
Yeah, absolutely. I appreciate the clarifying question. So when I say low-hanging fruit, again, they don't have to be experts. They just have to look at something and go, that doesn't feel good. So that allows it now to go ahead and dig into. And unfortunately, there's been a lot more recently, especially of, we'll say, newspaper articles and situations where, SPDs, GI labs, just even regular clinics have been hammered for lack of, we'll say, accountability with regards to the reprocessing standards that are necessary to protect patients. So there's probably at least one a month that you can pull out if you have the right articles and you're doing the right searches. We just had one recently in the Kansas City market, right? That hurts, and it brings a lot of attention. And it's not just an SPD issue now, because it's going to affect patients and then and ORs and throughput and infection prevention, and you're touching a lot of lives very, very quickly.
So let me segue from your comment about the accreditation surveyors, and we don't want to paint with a broad brush and say what you didn't say, which we don't want to act like none of them know anything about anything that they're doing. But we've all experienced, if you're on the clinical side, we've probably all run into surveyors who know enough to ask the questions or know enough to dig a little bit deeper, like you said, but maybe they're not the expert that we should be if we're in these departments, if we're running these departments. But, that expertise has to come from somewhere beyond just experience in the department. And this kind of goes to what you're saying, even about your background and exposure to the regulatory side. So my question is, these reprocessing standards and guidelines, these HLD guidelines and recommendations out there, what are the big ones? And if you were sitting down across from a surveyor who's about to go in to a system and about to assess, what are the ones where you'd be like, you may want to pay extra attention to what these couple of guidelines or these documents say?
Yeah, so most surveyors are going to be aware of your policies when they first come in through the door. So those are what your operation should be based off of. But we all know our policies should be based off of evidence-based practice. So it might be AORN, it might be AMI, it might be ASGE, it might be SGNA. It might be some hospitals are actually tied to those standards pretty heavily, and actually that's their policy as well as their state laws. So it depends on where you're living, it depends on where you're sitting within the United States. But ultimately, they said all of those come back to how is your policy written and what is the evidence-based practice on that. A lot of the surveyors are becoming more intelligent on the nuances, the little itty bitty information that does come into those standards. You've got Joint Commission now sits in some of the AMI standard writing, so they're fully aware and they want to be and they pass that information along to their surveyors. The state departments are starting to actually hire ex-SPD people to do those things. So they're
Those
by no
dirty
means are they
dogs.
neophytes. They're not neophytes. They
Right?
are absolutely ready to move on things, and that's why they can be dangerous and ask those questions that do unravel a ball of yarn very, very quickly if you don't have your ducks in a row.
Yeah. So it's a good dangerous. My kids are getting into the Chronicles of Narnia, and I'm going to
Yeah.
butcher the paraphrase, but there's kind of a quote in there of is Aslan, is he safe? And the quote is, no, Aslan is not safe, but he's good. And it's very similar to this, right? Nobody wants to get caught on an accreditation citation, but
Mhm.
on the flip side, no one wants to intentionally be doing something that's unsafe that could hurt a patient. So all of this that we're talking about in the education and the inside and the guidelines that are accessible to us as clinicians, and now also to the Department of Health or to the accreditation side of things, um, that's good. That's ultimately good. That's what we want.
Mhm.
We just want to know before we get cited, not after we get cited. Um,
Right.
so, what about these? Like, a lot of stuff has gone on, as you said, in recent years. There's a lot of news articles that has kind of brought this to the fore, the importance of HLD. Um, on the guideline side, what's been the latest shifts? I know we had a session earlier today about ST91. What else has been going on out there that specifically in this accreditation conversation, you need to be aware of if you're preparing your facility to pass your next visit?
So again, start looking at your policies. Make sure that your policies are up to date. Again, if they need to be updated and you're not going to have the time frame in terms of the window, that's fine. But understand that you're going to have to explain why you're working through that. So ST91 just came out roughly a year ago. Most hospitals are still probably working through what they're going to adopt, what they're going to go ahead and pull in. So as long as you have a plan of action around that, that's going to be fantastic. The other piece around that is when you get to those standards. So what standards are you going to go to? So in the GI world, you got ASGE, you got SGNA, and you got ST91. Which one do you want to use? They all roughly kind of speak the same language, but ST91 is the most cutting edge at this moment because ASGE and SGNA actually base their practice off of those standards. So there's actually a little bit of a dirty secret. Some of that group, ASGE and SGNA, did not necessarily want to buy into those initially. So there was a nice white opinion paper that came out from both of those groups saying, hey, we're not going to initially sign on this. I believe they've softened on that. I haven't looked at it recently, but that's a perfect example. Which one are you going to use? Because if you use ASGE and SGNA and you're using their older copy, it doesn't line up necessarily completely with ST91. So you can get yourself into some serious trouble if you list in the policy, we use ST91 and ASGE and SGNA. So really make sure that you are consistent with how you're going to hold your processes to account.
Yeah. You keep coming back to department policies, and I think everyone should be hearing the priority of that, but I just kind of want to give you one clear opportunity to speak to this because as you're being trained, I think, as a new technician, and like you're studying, like maybe for your certification exam, like you got to memorize all these acronyms. You got to memorize, FDA, you got to memorize CDC, you got to memorize Joint Commission, you got to memorize what is Amy or who is Amy, right? It's not a she, it's a it, it's a group, right?
Yeah.
And yet you keep speaking like policies are what's driving the critical decisions that these surveyors are making in the accreditation visit. Clarify that just for people like me who need you to just bring it down one notch, like simpler for me.
Absolutely. And again, I appreciate that. So all of those survey bodies are going to come in and they're going to go, how are you doing this process? And everyone's going to go, including your frontline staff, we follow this policy. We follow this protocol. Protocols are typically based off of policy. The minute that you're not following that, and I'll give an example here in a second, that's where they're going to come back and say, you're not following your own policy. What's this evidence to this policy and why is it now counterintuitive or why is it being followed?
Hmm.
So an example, everyone has in every one of their policies at this moment, follow the IFUs. Okay, device IFUs can be very convoluted. Sometimes people just meet them, some people over exceed them, and that's fantastic. But if you don't have that in policy, I'll give the example around ATP testing. ATP testing is not required by IFU in some devices, in some it is. But if you're now saying we're doing ATP testing on all devices, but you're only doing it on some, you're going to get in trouble. The surveyor is going to ask questions. Why do you choose this device versus this device? And now it goes down a rabbit hole. And they're going to start nitpicking at every little piece that comes out of that of, well, you do this for this, but you don't do it for this. Okay, next thing, you use this cleaning agent, but not this cleaning agent. Why? Who made that determination? And it very quickly, like I said, is that ball of yarn, start pulling on the strings. Blop.
So we've got a really good question that I'm going to throw to you, but remind me to come back to that policy point that you just made because it's really important. Got a question in here from Lori. If you don't adopt the newest version of ST91, is it okay to state that you're going to be following in your policy the prior version? And if so, how would you best situate yourself to successfully navigate this? And let me just put a little caveat here. Jason is not an attorney. He doesn't work for your health system. So, make your own decisions. This is your opinion that we're asking here. Okay.
Yeah. So I would state, Lori, that first things first, make sure you have the conversation with regulatory. You've got infection prevention involved in your discussion around that policy, because ultimately they're the ones that are going to have to also answer for this. So if they're saying, yeah, we're using the most recent, you're not saying that, that's where you can get into some serious trouble as well. So in terms of how you want to go about doing it, it's based on your policy. They're going to ask the question, so why aren't you using the most recent update? And you better have a very good answer or an explanation. The reason why those policies are not policies, your standards are being updated is because there's new evidence base that provide those provide the backbone to those standards. So, okay, you're not using the new one. The last iteration of that was 2015. Correct me if I'm wrong on that.
Yes,
but so that's almost 7 years, almost 8 years now. A lot has changed in terms of the reprocessing of flexible endoscopes and else like that. So you don't want to get caught with, well, we just don't want to deal with it because that's how we've always done it. Very, very dangerous.
It's a little harder to meet, so we're not going to go with the. Not that that's not what Lori's saying, obviously, but it's still better than the CDC guidelines, right?
Absolutely.
Updated
Absolutely. CDC is only 2008, so hey, we use the CDC guidelines. Okay, well, or not guidance. That's actually reg in that sense more so because it's a federal body. But okay, we use that. Well, okay. That does supersede standard, but it's not up to date. So, if you can pull it out, for instance, they still recommend that you can do manual HLD, high level disinfection, through a bath of Cydex. Is anyone, if you're doing that now, that's fine, but understand that the new standard is pushing away from that because of all of the misses and concerns that come with that.
Right. What would you think? Just because I know there's a lot of folks that are out there asking this, not only about ST91, they're probably asking about ST108 now that's new on the water side. But if you're going to try to make the argument, especially for 91, like you mentioned, where there was some debate in the industry between these various groups and, physicians especially, if you were going to say, we're going to follow the old version, we're just not going to update to the new version, is a risk assessment enough? Is that a good place to start with saying, on this point, we're going to do this, and say no? Like, how would you kind of, go ahead.
I would say that actually is a good starting spot. But, to prepare yourself for that, because as you do risk assessments, you're going to also have to pull in that evidence-based practice. Well, that evidence has now been updated based on the new standards. So you might do your risk assessment and say, yep, we're not moving off of this, and here's why. But then there's new data out there that you also have to necessarily pull into the risk assessment. And they will ask those questions. A surveyor will go, okay, you made a risk assessment. Great. What's this based off of? and you did it most recently, like say in the last 3 months. Cool. Well, why are you using this assessment and you're using data from 2015?
Right.
There's
Right.
more up-to-date data, so now you have to answer for that piece. So a risk assessment is absolutely important when you want to deviate a little bit, but like I said, you have to really have your P's and Q's minded in terms of what is the most up-to-date information. And again, it doesn't have to be, maybe it's an independent study within your hospital. You can do those pieces as long as you're not doing we'll say off-brand reprocessing, which means outside of IFUs.
Yeah, that's a fantastic point about the research and the data, and it's another reminder, like we said many times in other contexts, we need more data in our industry. We need more study and more research that's just out there, for the perusal of clinicians, but also, to better educate and to form the evidence of these guideline updates and the policies and the risk assessments that we're laying out here. So that's a great point. We got another question here, and this is kind of curveball. Are you familiar with AAA HC? And if so, are they going to be focusing kind of the same as Joint Commission on these types of questions that we're laying out? And you got any insight on that?
Unfortunately, I'm not familiar with that group, so that's a little bit. I'm glad to sit down and have a further conversation. I'm guessing that's another accreditation body. There's a couple of them out there. There's Joint Commission. There's DDI. I know
DNV, FGI, all the alphabet is coming.
Yeah, there's exactly. There's the alphabet agencies with in regards to accreditation. Again, you definitely they're going to follow kind of the same practices and standards and operations there. What's your policy? What's it based off of? And are you applying what you've learned, what's already learned out in the industry to your new policy or to your current policy to make sure that you're protecting patients to the outright?
So speaking of policies, thank you for saying that, because you reminded me of my follow-up like 20 minutes ago. So coming back to this,
It's all good.
Really important to call out, as you did, that these surveyors are going to be saying, are you following your policy? And so the temptation could be for folks to sit back and be like, well, okay, if they're going to be holding me to policies, I need to be as vague as humanly possible with my policies to give me as much leeway out there as possible. But I want to tie this into the title of this session at the system level. What function and how do you recommend us balancing the impact and the function of good, clear, strong policies to standardize what you want to happen and what you need to happen in these HLD departments versus not putting too much at the table that you can hang yourself with on the accreditation side if you're not following all the P's and the Q's?
Yep. So you just nailed it. It's a double-edged sword. So if you go too far one way, you're slicing off your left foot. If you go over too far to the right, you're slicing off your right foot. It is definitely a balance. What I will tell you is think of a system policy as a giant umbrella. Okay. So ultimately you want it to be able to cover all of the basics. It's going to cover, maybe the things that you absolutely don't want, non-negotiable. Maybe storage, maybe if you're doing double high-level disinfection, if you're still following that FDA tenet, maybe ATP testing, whatever those cases may be. You don't want to be so prescriptive that you are saying that it's every scope every time, because you get into that world, you're going to be in trouble. But, you want to, again, think of it as a giant umbrella. Now, at each individual facility or even at each individual department, you can have, we'll say, protocols or standard operating procedures that can kind of boil up, in which case you now create those additional guardrails to a specific department. Maybe it's a specific, and again, this is negotiable across, and that's why it's so important you have the conversation, not just just you. It's a conversation with a collegial group that includes infection prevention, regulatory, the operation leaders, your doctors, your quality representatives. Like it's not just one shoe fits and that's that. You have to actually take in all those little additional pieces. But truly, it's think broad, and then as you get closer and closer to where that reprocessing is occurring, narrow the scope.
I like your pun.
You
Yeah,
got it.
endoscope.
Hey, I knew you're sharp. I got you, buddy.
As you know, that's why I'm here, right? Um, so, you kind of alluded to this earlier in the career conversation, but I think it's a good time to bring it back up. At the frontline technician level, we've been talking like a lot about leadership, right? Like, how do you write your policies? How do you think about your policies? How are you connecting with and speaking to these surveyors directly from that leadership side of things? But from the technician level, we all know now, one of the favorite things for surveyors to do is blow right past the manager, blow right past the director, blow right past the supervisor, and find that frontline technician that's in PPE back there, back in decon, and that's the person that they want to talk to. Um,
Mhm.
so, how would you encourage technicians to stay abreast of, to learn about all the shifts and all the guidelines and all the little nuances that you've just been sharing with us? How do you find out about those? Because it's not like if you just clock in every day to your department, you're just going to randomly come across that kind of information.
Yeah, absolutely. So, I mean, you kind of are, well, you just alluded to it. It's education, right? So, again, when are you going to go ahead and do it? I think oftentimes we want to be spoon fed information. And I think the newest generation needs to understand that we were all in your shoes a long time ago. I mean, I can't believe it's been 21 years. But for me, I mean, my first question, very respectfully, when I got in was, okay, why do you do it that way? And when people would ask, I asked the question, okay, I'm going to do it because you told me to do it that way. Then it was cool. I did it. Why? And just continuously trying to find the right people that are doing the why and explaining that why. From there, oftentimes I would get, well, that's how we've always done it. I would go to the next person and find that information to the point where I think it's probably 2 years in when I found out that Amy was even a body in that sense. It
Right.
wasn't a person, as
Right.
you put it, right? I'm like, who's this Amy person? So got the book and I actually read the standards cover to cover because I wanted to understand what I was doing and why I was doing it. And when I found that out, wow! I mean, it shifted my whole perspective. We do a very good job now with the certification aspect. If you're bringing them on and growing them from the front end, if you're doing we'll say cohorts of brand new techs and trying to grow your own because we frankly have to do that nowadays, you actually are going to be a little bit better off because you can get them on the front end. I believe in believe in exposure, review, educate, and then exposure. Okay, so expose them. They may have never been into the department before, but they've at least seen it, heard it. Maybe that something will ring a bell. From there, you get them into the department, you review it with them. Again, it's still going to be so, I mean, a second language or third language in some cases. From there, bring them back, educate. And so that's why it's so important. It's not just, hey, go take the test, go read the book. You need to get a didactic portion, a hands on approach, so that from there, once you've educated, now you bring them back and expose, and they have to teach you as the educator in that regard. So that's frontline staff. But again, frontline staff also have to understand you're not going to be spoon fed in this industry. You have to take some ownership on yourself to go ahead and move forward. I will be honest, most people don't want to hear that. But I will tell you, when I hire people, that's what I'm telling them. I expect you to go ahead and ask questions, and I expect you to also do some of your own research and bring it back and ask questions.
Yeah. Yeah. Well, that asking questions too. We had a great comment in here from Stephen Gray. He says, training is the how, competency is the why. And, asking the questions is how you get to the why.
Mm-hmm.
And yeah, that, I don't know if you use the phrase or kind of use the analogy around the certification piece, but I remember the different feeling that I had when I was first studying for certification versus the first time that I got my hands on ST91, and just reading through the depth of the document and the specificity of the document, clicked that whoever wrote this, right? Like at that time, I didn't really know how these guidelines were put together, how the recommendations were drafted, but I was like, whoever put this together has done what I'm trying to do.
Bingo.
And yeah, and they see the
It's
challenges and the nuances,
yeah,
and it just
it's a different mentality once you have ownership. Great book for anybody out there. I'm not a plug for this by any means, but look up the book Extreme Ownership. Teach your team to have extreme ownership of their processes, their education, their opportunity. It's written by a former Navy SEAL. I just appreciate that grit to have extreme ownership. So again, it's your career. You may not be. Most people don't have the opportunity to stay at one hospital system for 30 years. Just be honest. But it's your career. So take ownership in your career. And if you are just 5% better than the next guy over or the next gal over, you're going to be fantastic. But that takes, again, that ownership to go ahead and educate yourself with all the resources that are out there. And it's especially even more robust out there with the likes of Beyond Clean. Amy's out there putting out emails all the time. You've got, if you're on LinkedIn, OMG. I can get lost in there. Turn off your freaking Facebook and Insta whatever and TikTok, this, that, and the other. Get on to LinkedIn and read all of these posts that are the people that are putting up things. And again, not everyone posts. I'm one of those people, I don't post, but man, I absorb so much by reading from other industry experts just because I'm going to go ahead and get involved in it.
And yeah, there's even more kinds of platforms out there. Like we've got a Slack channel that we have a bunch of people on through the advisory group. There's Telegram groups out there. There's Signal chats, like you name it. Getting that perspective to what you said very early on in the interview, that we're not doing this in isolation of each other. The stronger we are, the safer we are as a system, the safer we are as an industry. And you're just not going to know, to your point, you're not going to be spoon-fed that information or the updates or the changes or the studies. You got to go out and seek it. And it's so easy, I know, clocking in as a technician, you've got your job to do, you got your policies to follow, you got the volume coming in, you got expectations, for the patients tomorrow. Like everything's pressing in on you in the immediate. It's easy to put the blinders on and just put your head down and work every day, go home, then come back and do it again, and not be moving forward or not be abreast of all the changes and everything else that's happening all around you in the industry. And that's how you wind up in these survey scenarios where like these accreditation surveyors come in and be like, why are you still doing it the way that we were doing it 10 years ago? Like, because nobody asked questions, or no one told you
no one asked questions. Nobody
the world has changed.
Nobody knows the status quo. And if I might add right here as well, again, all of this information is at your fingertips as a frontline person, but also supervisors, managers, directors. You should be doing the same thing. But moreover, do you not think our surveyors also have this information at their fingertips? So think about that. Oh, well, I didn't read that today. Okay, well, I can tell you there was a surveyor that did read it, and they're going to bring it back to you, and they're going to hammer you on it, and you're going to be behind the 8 ball. I was just one of those people. I never wanted to be behind the 8 ball. I wanted to run circles around the surveyor.
Well, speaking of that point, one of my questions that I wanted to pose to you is, we do talk a fair bit about in SPD that we want to be the experts on our jobs. And no matter who it is coming into our department, if it's our customers, like if it's a clinician, if it's the nurse, we want to be the one to speak expertly about our process or about our policies or about the guidelines. But that's also true for surveyors as well. We want to be able to educate them. But my question is actually the opposite. What can we learn from surveyors while they're in our departments or while they're touring our systems, even during the accreditation visit? Is there anything we can glean from that resource that's now in front of us that we may not see again for 2-3 years?
Absolutely. And in fact, that's actually kind of what moved me into being, a quality director and the whole 9 yards, is building those relationships and understanding what they're looking for from their eyes. Sometimes I've had surveyors tell me, I never noticed that about SPD. And it's because they're not focused on that. It's not a big deal to them. Whereas the thing that is a big deal, it is. And it's learning that lens that they see things through. It also helps, like I said, from learning from them is they're looking at it from, again, a system perspective, the downstream and upstream effects. I think a lot of people in our industry, we get into the tunnel vision of, okay, I'm here, I'm just reprocessing a scope. Okay, cool. Well, that scope goes to the room. It's got to be documented in the EMR. The nurse at the bedside has got to help the doctor get the patient, and all that while all those things that are going on, they're looking at 10,000 things, and you're focused on the 5 things, right? In terms of a reprocessor. So it really builds you to understand and understand the business side of things as well as the clinical side. I've been in rooms where I'm like, wow, I had no idea, because a surveyor will ask a question, and I'm like, I have no idea that they were looking that in depth on, what's their more comorbidity score, right? You don't think about it. You just go, okay, cool. They're here for a surgery, or they're here for a GI procedure. Done. And when you look into it, they want to know that information because, well, what does that lead to? Potential SSIs. And you want to know that as a reprocessor, because you're going to have to defend yourself potentially if there is an SSI. Well, did you do the processing correctly? Well, yeah, we did. But, well, they still got an SSI. They still got a surgical site infection. Well, maybe it's a comorbidity issue. Maybe it's, the person wasn't maintaining their incision. I don't know. Right. So it's important to ask those questions and see it through their lens.
Yeah. Yeah. So since we're talking about accreditation surveyors again, and we're kind of bouncing between guidelines and, policies and leadership and technician and learning, but we're back to accreditation again. And I'm going to ask you a question that I just thought of as you were giving that answer, but it's a really hot potato. Okay. So buckle up. I kick accreditation a lot through our platforms and media. Like, I really beat them up in the areas where I feel like they could improve. And, sometimes I'm not very nice about it. Maybe this is my confession to the world here.
Confess.
That's right.
Shame. Shame.
My question is, in your commitment to quality in your role, you're going to have an accreditation visit once every couple of years. And then you're going to have a Department of Health visit, Department of State visit once every couple of years. Maybe you'll have some other like audits and stuff in between. But even take yourself out of your system, and you've been in the industry now for 2 decades. You're very familiar with this process is. Is it possible for a system or department to pass their accreditation of their HLD and still not be safe?
Yes.
Okay.
Was that too fast?
I mean, maybe my setup was too long, so I gave you too long to think about it. I don't know.
No. So
why?
Let me explain the why on that, because again, we're looking at policy. Policy determines how we do things. Well, you may have written your policy, and you may have, we'll say, had some oversight on a step that occurs that is necessary. I'll give the example around drying of endoscopes. If you read ST91, even the previous version, it was you're supposed to store the scopes after the lumens are completely dry. Okay, first off, how do you test for that? There's no way without contaminating the scope again. Actually, there's a way to do it. There's a friend in our industry, Corey Hofstad, that has shown many people how to do that process. So if you have questions on that, definitely reach out to her on LinkedIn. But yeah, there's a way to do that. So, okay, it's now not dry. You've now put it into storage. Is there going to be potential growth? Yep. There's studies out now that show that that's going to be the case. But your policy didn't say anything about providing dry scope prior to going to storage. So you're not going to get hammered. You're going to get a pass. You're going to go ahead and get a thumbs up from the accreditation agency and say, cool, you're good to go. And in turn, you potentially could be causing harm to a patient. I can give other examples, of course. Sterile processing. We all know the good old FDA of 4 minutes, 30-minute pre-vac. So 4-minute pre-vac, 30-minute dry time. Again, well off our thing around HLD, but did you follow all the IFUs? Well, you pull up the IFU and it actually requires a 5-minute sterilization. Did you hit sterilization? You have all the paperwork that says the device went through sterilization, but did you actually sterilize it? Mm-hmm. So manual HLD, again, we're doing all the processes according to Cydex OPA. Okay, cool. That's fantastic, but you're using a manual tub. Well, if you read the Cydex OPA IFU, and back to IFUs again, I'm sure somebody beat the heck out of that in the last couple of people's
Yeah.
talking. But yeah, you don't follow the IFU. It says you're supposed to have 3 full rinses of the equal volume of Cydex OPA. How many people are doing a gallon of DI water? Number one, DI water. Most people don't have that capability in those small clinic settings. And you're using, a regular gallon bucket that's actually measured out. It's
Right.
not in your policy, but other than maybe you follow the IFUs, and that's where a surveyor might go, hey, they're doing a pretty good job. They're mostly catching all the T's. They forgot an I here and there where they forgot to dot it, but it's serviceable. And that's where I think we do a disservice from an accreditation perspective. That's why I'd love to see the accreditors become way more, the surveyors become way more involved in our world. And that's on us as again, bringing them into our department. Don't take it as they're in my department, boo, get out. Give them the information that they're looking for. But then after the survey, ask questions. That's what I did. I ended up making a lot of friends with surveyors in the Joint Commission because I'm like, hey, walk me through why you didn't see this. Or can I give you an example of at another facility that I walked into? What would you score this?
Right.
And
Right.
just giving that information. And it's funny how many people, surveyor wise, go, I had no idea. Man, we
Yeah.
really need to have people like you educate us. It's cool.
Yeah. So let me ask you another side of this question. It's not a complete flip, but it's going to be similar because, again, of just the nature of accreditation, the complexity of what it is we're doing. If a system does not pass their accreditation visit with flying colors, that doesn't mean that they completely failed, but maybe there's some citations, maybe there's some serious ones that have to be followed up on. In our industry, especially at the leadership level, but this also goes all the way down to the frontline technician, that's a pretty serious deal mentally. Nobody wants that. We got a lot of pride. You see it all over social media. Like when you pass your accreditation visit, everyone's like, we did so good. We got a high five from the president. It was awesome. But no one's ever like, oh crap, I just got cited twice. Want everyone else know, like, we don't advertise that. And yet everything that we're saying here today and the manner in which these citations happen many times, the reason why around the policy, particular events or what have you, how would you encourage a leader or even speak maybe to like a C-suite level that's over a leader who just got a couple of big citations in their HLD program? What would you say, hey, this is not good, obviously, but it's maybe not as bad as you think?
Well, I mean, this is, my faith in Israel. So don't take this in any way, shape, or form. But I mean, ultimately, God doesn't give you what you can't handle. So ultimately, there was an obstacle put in place right there for you to try to overcome. You maybe didn't have the right opportunity. You didn't have the right, maybe knowledge base. Now it's your turn to go back and figure out how to overcome it. Now, in terms of the conversation with the C-suite, I'll be honest, I've been one of those where I, walked in and I had to try and fix a place and we got hammered and I had to explain, here's all the things I'm doing currently. This is going to improve X, Y, and Z. Was not aware or again, my bad, did not take into account this other piece. Here's what I'm doing to go ahead and fix it. Right. Here's my timeline to go ahead and do it. At that moment, truly, it is all about communication. It's about a relationship with your leader. And explaining, what is that going to look like? It's going to be, the expertise deference. My leader hired me to go ahead and be that expert in that world, to be that subject matter expert. So let me be that subject matter expert. That means that you may not have all the answers at your fingertips, but I'm hoping you're coming back to me to have the conversation and we can lead from the front with those issues and concerns. Again, it's not pleasant. Nobody likes to be, on the failing side of things, but frankly, if you're not failing, you're not moving forward. Right. So again, we don't want to be failing all the time, but if you fail once, man, you'll never forget that oops, and you'll never have that issue come back to haunt you because you'll never ever have that not be on your radar. If that makes sense.
Yeah, your scenario and kind of how you would speak to the C-suite definitely aligns with the book recommendation, Extreme Ownership, because what you said is, yes, this is on me. And either I didn't know about this or I should have known about it. Or, maybe I made the wrong decision, right? But you didn't deflect. And I think that's very important for especially leaders, but
Mm-hmm.
also technicians, to, if there's areas that we can own, and even like extreme ownership is like even the areas, that maybe it's very clear it's not your fault, you're still grasping to try to get your arms around, because if you can own it, then you've got responsibility and scope to fix it and to impact it. I don't want to get us off on an hour of extreme ownership. That would be a good session. Maybe we'll get you back on for that topic.
Yeah.
But yeah, to walk away with and just realize we have all, if you've been in the industry long enough, we've all had those, oops, I should have known better. And, to not also use it, and I think this would be a temptation of mine, to march in the C-suite and be like, I told you guys, I've been telling you guys for the past 4 years, we're going to get cited for this, and here we go. Not to do that.
So let me raise that
good.
recommendation to everybody on this call. Don't do what Hank would do.
Yeah,
Okay?
please don't do that.
You've heard the expression WWJD. What would Jason do? Oh, I mean, no, I'm sorry. No. In all seriousness, I mean, it is that extreme ownership, but it also is, yeah, I mean, maybe you have been preaching to the choir or preaching and screaming from the hilltops, this needs to be done. I can tell you right now, if that is the case, and you come in with the ownership of like, hey, I take ownership of this, but I do want to point out that, hey, we've been talking about this. You're going to have a friend in the C-suite that recognizes that, and you're going to have those, we'll say, opportunities to maybe improve your processes. Maybe you need an additional AER. Maybe it's you need an additional person. Maybe it's, hey, we need to take a look at a unit of service measurement. Whatever the case may be, because you walked in with a mentality of like, yep, it's my bad, I own it. It's also that mental game too. If you sit there and say, hey, that wasn't my fault, that was your fault, you didn't listen to me 4 years, you're deflecting and you become the victim.
Right.
I want ownership. I want to be the victor in this situation. So I'm going to go ahead and take ownership, and I'm going to force you to come alongside with me, because we're going to be both victors in that sense.
Yeah. Well, one more thing that I would put out there to do this very thoughtfully too, like your, I love your approach, because it's not a us versus them at that moment. It's whatever's going to happen moving forward to fix this citation. We're going to need C-suite on our side. Whether or not they were there before, we definitely need him now. But if you're a technician or a department leader, definitely at the system level, when you got multiple facilities that you're trying to identify every little thing that could be caught, I would highly recommend to be documenting those things proactively, not as necessarily like the annoying squeaky wheel. Like, you do need to be squeaky at times. You need to make sure to keep it on the radar, but not so much so that it becomes like, okay. But if you can get it documented ahead of time and be sharing that around the IP circle, the quality circle, the C-suite circle, so everyone's like, they can't, in good conscience, when they get cited, say, I didn't know about that, then you're in a real good place, because you got it written down, it's been circulated, everyone's like, yep, you're right, now let's get to work and get those things fixed. So
if I may add there, Hank, truly, you just kind of touched about it. It's about the relationships, not just the relationship with the C-suite. It's also the relationships with the other departments that this touches. So IP, regulatory, OR, GI. Again, having those relationships, because ultimately, if it's hey, we have been telling you for 4 years, and it wasn't fixed. Now you've got OR, you've got GI, you've got the SPD team, you've got the GI team, you got everybody and anybody that going to the C-suite. You can't. It's not one voice. It's a crowd, and you can't yell over a crowd, if that makes sense.
Right. So let me come back to that 4-year thing, because this is going to be an important question. But before we do, I want to go to another question that we got in the QA. We got about 9 minutes left. So if you got any questions you've been holding on to, shoot them in the QA right now. But we're going right now to Christy's got a question. What process in sterile processing, and I'll kind of broaden it out here to HLD as well, What do you think has the greatest risk of non-compliance with these accreditation visits? What's the lowest of the lowest hanging fruit? That fruit that's like an inch off the floor. You just want to kick like a football when you walk into the department. In your opinion, what is that?
I would say it's kind of the belief that all IFUs are created equally. So definitely take a look at your IFUs for devices, because you'll sit there and go, okay, cool, I've got an Olympus scope, and everyone has these in the GI world. But if you go into the GI lab specifically and then look at, I've got a colonoscope, a Q190 duodenoscope. There are differences in those IFUs just a little bit that can bury you if you sit there and say, we're just going to meet the minimum of this scope. There's nothing wrong with exceeding the max on the IFU. So for instance, we'll go with delayed reprocessing as an example. Delayed reprocessing, for those who are kind of new to this world, if you don't hit a certain time frame between point of use and manual cleaning, you have to put the scope into delayed reprocessing. Delayed reprocessing, depending on the scope and depending on the manufacturer, is a different time frame and a different process. But if you go ahead and say, yep, we're going to call delayed reprocessing as an hour for every scope, you might hit every scope, you might not. So understand that, don't just assume that your IFUs are identical to the sterile processing world. 4-minute, 30-minute pre-vac, 4-minute pre-vac, 30-minute dry time. That's the standard. No, there are devices, specifically in the vendor world, where it's 10 minutes of sterilization. And a lot of people don't hit it because they don't look at that IFU. Now, the surveyors are getting way more intelligent on that, and they will actually hold on to those really oddball ones and go, hey, do you have that here? Really?
Yeah.
And then also, again, back to IFUs, everything that you use during that process has to be validated and in terms of the IFU. So don't just assume that you're using an AER, think like a Medivator, and you're using Rapicide, which is a variant of Cydex OPA. You're putting your Olympus scopes in there. Understand that that's a different soak time. You have to have those IFUs match up to that. Well, the other scopes are fine. Correct. That doesn't mean that this one is. Does that help?
Yeah, no, that's some great advice. IFUs, no surprise, coming up again. That's gonna be on all of our tombstones, right? The IFU, I think is.
I make the joke. It's IFU, IFU, not FU.
That's right. That's right. Remember your spelling.
Right.
So let's get really political and strategic here as we kind of move to the closing minutes. And I want to speak again to these system level, or if you're in a system, you're in an HLD department that you've got a system leader, or maybe you want to become the system leader. So you're trying to think in these kind of categories. One of the best ways to get something done is to prove to your C-suite that if we don't do it, we're at risk of getting cited, right?
Mm-hmm.
However, the alternative is also true, and this is my question. If you have successfully passed an accreditation visit, it gives a lot of firepower to your C-suite to be like, y'all don't need that. You just passed your accreditation. We're good for another 2-3 years. Whatever it is you're asking, evidently not important and not necessary for compliance because we've got the golden ticket. How do you navigate that if you're one of these leaders like, we got to do this. It's the best practice. It's the way to move forward. It's at risk quality for patient safety and everything else. And yet you're staring accreditation in the face.
So 2 things. It's going to be, again, relationships. You've got IP, you've got regulatory next to you. They're going to be always one of your best friends in terms of, hey, we definitely need to make sure that we're a highly reliable organization. And honestly, that's where it really comes back with the communication aspect. So highly reliable organization, what does that mean? Everyone throws that HRO terminology around, and frankly, it kind of aggravates me because it becomes a catch-22 for everything. But ultimately, if you really look at an HRO, you're looking at every single ounce of failure that's in a system and trying to squeeze every ounce of that failure out of the operation. That means it is constantly being relooked at, revamped, being looked at by different sets of eyes. So an example like what we did at one of my facilities, we went ahead and said, okay, we're going to have you as the operational leader do an assessment and do like a tracer or do a quality assessment. And then we're going to have a trust but verify process behind that. And that's where somebody like me, an expert in my field, comes in and goes, I'm going to assess it. You're telling me you're scoring a 95%. I'm telling you you're scoring at an 80%. That's a 15% difference, and we're not even hitting 100 yet. What is those failures? What are those things that we need to help you get over? And that could be education. That could be education from my side. Maybe I need to train the leader that, again, my lens of what I'm looking at versus what they're looking at. So HRO is where I'm going to come back to the C-suite, because a lot of them will use that parroting, HRO. All right, okay, put your money where your mouth is. What is an HRO? And I'm a little strong there because honestly, I've had those conversations where, well, we just passed the survey. You crushed it, Jason. We don't need to really kind of focus on it. Yeah, we still need to, because frankly, ST91 just came on out. That's a new change. ST108 just came out. That's a new change. Oh, by the way, ST79, that's going to be another rework here coming out. So it's always changing. And then you really want to blow their mind, pull up the MOD database. That one there, I just love. For those of you who don't know what the MOD database is, that's the FDA database around manufacturer devices and defects. And it basically tracks all the trends and issues and concerns around any device that's on the market. Frankly, we need to be doing more of them, but that's just me. I know that Dr. Muscarella will just love hearing that.
That's exactly what I was thinking about as you're talking.
But yeah, literally, that's what needs to happen, because that's where we're going to highlight issues that are coming out that we also need to address that is not coming out in the standards just yet, because that's what the standards are going to be based off of from the evidence, and it cascades. So yeah, I'm going to push back on a C-suite telling me, oh yeah, we did great. You can stand down. Again, highly reliable organization. I'm squeezing every ounce of failure out of that process.
And as you're talking, we got a great comment in here too. Goes to what you were saying about the highly reliable with the new set of eyes on the process. And they said, hey, don't forget, you're going to get a new set of eyes the next time around for the surveyor too.
Right.
And they may have their own priorities around the guidelines and the implications around the processes that you've been laying out. So yeah, you can't build your whole kingdom on one surveyor one time said that you're good forevermore and always. You do need to be pushing that needle forward. And I think, Jason, the big takeaway that I have from this session, I'm going to give you the last word, is to stay abreast of what's going on out there in the space, bring it home, ask questions, and collaboratively encourage all those around you, whatever role they have, responsibility they have, to ask questions about the process together. And then together as a department, as a system, as an industry, that's the way that we will ultimately move forward, not only creating a dynamic for excellent accreditation, but also excellent patient safety. So yeah, what's your last word? What do you want to leave us with today?
I would say that I'm going to just tell you 4 keys to developing a compliant reprocessing system. Again, developing HRO. First things first is communication. You need to be communicating up, down, sideways with all parties, as you alluded to. You want to have relationships. You can't go in and tell somebody to go ahead and change their process, especially when you're not an operational leader. I'm an operational leader now, but having learned how to have indirect relationship and indirect oversight really challenges you to actually get into their space and understand that world. 3, enterprise expertise deference. Make sure that once you've built those relationships, they understand you're the expert in this space, whatever that may be. Reprocessing, high-level disinfection, sterile processing. Again, combination of the two. You're the expert in reprocessing, and we need to defer to your expertise. You're the one who's staying abreast of all of these changes. And then the final thing is education, and it's education for you. Then it's educating the people around you, and then it's educating the system as a whole. Mahatma Gandhi said it best: you want to change the world, you change you. So change you first, and then you can go ahead and start changing the rest of the operations around you.
Wow. Well, start with education, end with education. And that's going to wrap up this session. Jason, tremendously appreciated your time today. And I know the audience did as well. We got a lot of great comments and questions in through this series. So thank you for being with us today.
Absolutely. I enjoyed it as always, Hank. Again, always open to having further conversations. And those of you in the audience, look me up on LinkedIn if you need any help. I'm always able to take a, an in message, whatever the case may be. I've obviously, again, I've been in the industry long enough, but I also do consulting if you need help with anything.